Hello everyone, starting with chapter 7 of illustrated textbook of Pediatrics, Accidents and Poisoning. Features of accidents and poisoning in children are accidental injury is the most common reason for children and young people to seek emergency health care. Accidents are most common cause of death in children over 1 year of age worldwide, and the majority are preventable. Poisoning is a common avoidable cause of harm to children. The features of poisoning are demonstration of pharmacology in action. Children need a safe, healthy, and nurturing environment to achieve their full potential. Accidents and poisoning are classified as external causes of morbidity and mortality, as are entirely dependent on the presence of an extrinsic environmental factor, for example, a motor vehicle or a swimming pool. Although the provision of a completely risk free environment is not possible or desirable, children and young people should be protected from external causes of serious harm. This is primarily the responsibility of parents, family, and carers, but all members of society, including health and education professionals, have important roles to play in advocating help to organize safe environment for children. Although external causes are the leading cause of death in 1-year-old to 14-year-old children worldwide, and until recently in the UK, they have declined sufficiently to now be the second most frequent cause after malignant diseases in the UK. And as shown in the figure, accidental injuries are extremely common in childhood. Approximately 2 million children and young people attend an emergency department with an accidental injury each year in the UK. Fortunately, the majority suffers only minor and temporary damage. However, for a small but significant proportion, the consequences can be life-changing. The fatal external causes in England and Wales for children aged 1 year to 14 years are shown in this picture. Survivors of significant injuries may suffer long-term disability and disfigurement and psychological harm. Accidents are the second most common cause of death in children over 1 year of age in England and Wales. Different types of accidents are prevalent at different ages relating to the child's development. Babies and preschool children sustain most accidental injuries at home, as this is where they spend most of their time. These injuries result from their natural inquisitiveness combined with a lack of appreciation of potential danger and poor coordination. Typical injuries are falls down, steps, and trapping fingers indoors. By school age, accidents are more likely to occur outside the home. In particular, injuries from road traffic collisions are the leading cause of serious injury, accounting for over half of accidental deaths in children aged 5 to 14 years. The majority of these children are pedestrians. Older children and young people may indulge in risk-taking behavior and underestimate the magnitude of the associated danger. Accident prevention, or more correctly injury control, is an important public health issue. Primary prevention strategies relate to the avoidance of the event causing the injury in the first place. Secondary prevention strategies include the provision of appropriate healthcare services for the treatment of the injured children. For example, specialized trauma and burn services is follow-on tailored rehabilitation. Primary accident prevention strategies typically tackle three main factors: modification of product design, for example, for road traffic accidents, vehicle child restraint design, and legislation change. Alteration of the environment, for example, reduction in speed limits or road layout design. Education of children and their carers, for example, public service announcements and school safety campaigns. Specific examples of these are given in the picture shown. Healthcare professionals are well placed to deliver anticipatory guidance as well as to identify and publicize risk factors. Implementation is usually more successful when supported by legislative change rather than education alone. The number of deaths of children in the UK due to accidental injury had declined steadily over the last 25 years. Head and neck injuries. Head injuries is common in children. Fortunately, in vast majority, it is only minor and a full recovery with no long-term adverse effects can be expected. However, it is also the most frequent cause of death and serious morbidity in children who have been injured. Initial assessment is therefore directed at identifying the small proportion of children who are likely to have sustained an intracranial injury and thus need neuroimaging. This assessment is based on the history and logical condition of the patient. Various clinical guidelines have been developed to help determine which children need brain imaging, which will be discussed in a picture next, and a case history. These decisions tend to be highly sensitive but not highly specific, resulting in many normal CT scans for every scan that identifies a significant injury. If an intracranial injury is identified, the aim of management is to avoid secondary damage to the brain. This is achieved by maintaining the blood supply to the brain while minimizing the damage for raised intracranial pressure. This may require surgical evacuation of intracranial hemorrhage and or intubation and ventilation to allow control of blood pressure and blood carbon dioxide levels, both of which affect cerebral perfusion. In infants with unfused skull sutures, significant bleeding into the brain and surrounding space may occur, leading to shock before neurological symptoms and signs appear. Significant head injury in young infants must always lead to consideration of possibility of deliberately inflicted injury. Children with severe traumatic brain injury can make a good physical recovery, though the period of rehabilitation may be long. Cognitive, behavioral, and mental health problems are common in these children, however, and specialist follow-up is required for early identification and intervention to try to ameliorate the effect of these problems on daily life. Neck injury resulting in spinal cord damage is very rare in children and is usually only associated with significant trauma associated with high-speed road traffic collisions. The most common neck injury is fracture of the upper two cervical vertebrae. The elasticity of cervical spine can also allow damage to the spinal cord without injury to the bony structures, i.e., spinal cord injury without radiological abnormality. Internal injuries in children are usually associated with severe trauma due to road traffic collisions and falls from significant heights. In particular, young children have less fat and a more elastic skeleton, protecting tightly packed internal organs. This means that impact force is distributed widely through the body and resulting in a greater possibility of multi-system trauma compared with adolescents or adults. Abdominal injuries are typically caused by blunt trauma due to seat belt restraints or bicycle handlebar injuries. Liver and spleen rupture may occur and become apparent rapidly, while bowel and pancreatic injury may take longer to become apparent. Close observation and imaging are necessary. Focused abdominal sonography in a trauma scan can be useful but must be combined with clinical judgment. Contained splenic and hepatic hematomas can be managed conservatively, but rapid access to pediatric surgery must be available immediately in the event of clinical deterioration. Chest injury, including pneumothorax and hemopericardium, are also typically due to blunt trauma. The pliable rib cage in children may allow significant injury to underlying organs. With little external evidence, there must be a high index of suspicion for these injuries in the event of a significant mechanism of injury. Now, the first picture that is shown is example of accident prevention. Accident preventions: falls downstairs, stair guards should be used. Window falls also needs stair guards. Sports injuries and car passenger accidents: experienced guides supervising climbing, walking, or canoeing expeditions. Close refereeing of scrums and malls in rugby. Head protection in horse riding and cricket. Car passenger accident: correctly fitted car seats. Drivers' legal responsibility that children use them. Bicycle accidents need helmets. Pedestrian road traffic and play accidents: redesign roads in residential areas, give priority pedestrians, separate off the traffic, reduce traffic speed with speed bumps. Walking bus schemes: safely walked to school, provide safe play areas for children. House fires, smoke and carbon monoxide alarms. Glass injuries: laminated safety glasses. Scalds: run cold water first, set thermostat to 40 degrees Celsius max. Thermostatic mixing walls: accidental poisoning. Child resistant containers, lockable cabinets, bed cloths, and furniture fires, flame resistant materials, fire guards, swimming pool and drowning, surrounding fence and window safety catches. Next one is head injury in children pathogenesis, primary damage, injury to, starting with injury to neural tissues, focal cerebral contusions and lacerations, diffuse axonal injury, injury to blood vessels, extradural, subdural, subarachnoid, penetrating injuries. Secondary damage, cerebral edema, hypotension, hypoxia, seizures, hypoglycemia, and infection, which are later causes. The skull is shown, head injury is shown, extradural hemorrhage, arterial origin, dura mater peel from skin. Dura mater still apply to skull, and in during the extradural hemorrhage, dura mater is peeled from skull. Subdural hemorrhage is venous in origin. Initial assessment and management. Initial assessment: airway, breathing, ABCD, disability, conscious level, pupils, conscious level in pupils, and in exposure. Is the child any of these: unresponsive, responsive only to pain, breathing inadequately? If yes, intubate and ventilate, urgent CT scan, urgent neurosurgical and intensive care referral. And if no, are any of the following present: suspicion of non-accidental injury, post-traumatic seizures, Glasgow Coma Scale less than 14 initially or 15 after 2 hours after injury, suspected open or depressed skull fracture, sign of basal skull fracture, hemotympanum, pana eyes, battle signs, CSF leak from nose and ears, focal neurological signs less than 1 year old with bruises swelling more than 5 centimeters on the head. If all of these are present, urgent CT scan. And if all of these are not present, are any of the following present: witnessed loss of consciousness more than 5 minutes, abnormal drowsiness, 3 or more discrete episodes of vomiting, dangerous mechanism of injury, high speed road traffic collision, fall from more than 3-meter height, amnesia lasting for more than 5 minutes. If in all of these only if one present, and then admit and observe for at least 6 hours, CT scan if further concerns. If more than one out of these are present, urgent CT scan. If nothing is, any of these are not present, no imaging required, use clinical judgment to determine if further observation is required. Now the history. Case history: head injury. Tom, a 3-year-old boy, is being carried on his uncle's shoulders when he falls 6 feet to the ground, banging his head on the concrete floor. He cries immediately but does not lose consciousness. He's taken to the emergency department where he vomits once. Clinical examination is normal apart from a 4 centimeter diameter firm swelling over his left temple. He's discharged home with advice to return if he vomits repeatedly, complains of worsening headache, becomes abnormally sleepy, behaves abnormally, develops weakness on one side of the body. Tom remains well overnight, but the following morning begins to vomit again and becomes lethargic. He's taken back to the emergency department where a CT brain scan reveals an extradural hematoma. As shown in the figure, Tom's hematoma is evacuated by the neurosurgeon and he makes an uneventful recovery. This illustrates how children with significant head injury may appear normal at initial presentation. It is essential to provide parents and caregivers with safety net advice to ensure they know to return should symptoms evolve. Now the summary: accidental head injury management. No symptoms or signs and benign mechanisms of injury, discharge home with written advice. Minor symptoms or dangerous mechanisms of injury, monitor for evolution of symptoms. Significant or progressive symptoms and signs, resuscitate. If necessary, CT scan, neurosurgical referral as appropriate. Now the choking, suffocation, strangulation. Choke is particularly common in young children who frequently put things in their mouths and lack the oromotor skills to avoid choking on them or inhaling them. In addition, their airway diameter is small and more readily occluded than in adolescents and adults. Food is the most common cause of non-fatal choking, followed by toys. Emergency management of the choking trial is outlined in the picture. Children may strangle themselves accidentally when clothing or bedding gets caught on furniture, particularly young children in cots, some following some tragic incidents. The possibility of strangling on blind and curtain cords have been the subject of a number of following information campaigns. The next is drowning. Drowning, the respiratory impairment produced by submersion or immersion in liquids, is a significant cause of accidental death in children. Babies and toddlers tend to drown in baths, paddling pools, or garden ponds. Older children get into difficulty in canals, lakes, and the sea. Once submerged, asphyxiation occurs with or without aspiration of water. Up to 30% of fatalities can be avoided by skilled on-scene resuscitation. If the water is cold, the resulting hypothermia can have a protective effect, and even in the presence of fixed dilated pupils, resuscitation should continue until the child is warmed up, as recovery may still be possible. Management of choking: assess severity. Severe airway obstruction, ineffective cuff. Mild airway obstruction, that means effective cuff. Unconscious, start CPR. Conscious child, 5 abdominal thrusts as shown in the picture. In infants, 5 back blows and 5 chest thrusts. And if it is mild airway obstruction, which is ineffective cuff, encourage to cough. Continue to check for deterioration until obstruction cleared or cough becomes effective. This picture shows abnormal Sir-Heimlich maneuver in older children. Place a fist against the child upper abdomen in the midline and grasp with the other hand. Pull backwards and upward to expel air from the lungs. In infants, back blows and chest thrust are recommended, avoiding abdominal thrust due to the risk of injury to liver and spleen. Now the burns and scars. Burns and scars are relatively common in children. This relates to the natural inquisitiveness and lack of sense of danger in young children and the risk-taking behavior of older children and young people. They are a significant cause of death, although typically death in house fires are due to asphyxiation from gas and smoke inhalation rather than the thermal injury. Inhalation of superheated smoke or steam may also cause significant airway swelling. This can occur when steam has been inhaled directly from the spout of a kettle or teapot. Injuries from house fires may also be complicated by serious injury as a result of, for example, falls from a height during escape. Assessment: immediate assessment of major burns comprises airway and breathing. In particular, check for evidence of airway burns, soot in the nasal and oral cavities, cough, hoarseness or stridor, coughing up, black sputum, breathing and or swallowing difficulty, blistering around or in the mouth, scorched eyebrows or hair. Early intubation if there is evolving airway swelling. Intubation may become possible with progressive obstruction of the airways. Circulation: early circulation compromise is rarely due to the burn injury, and the other sources of fluid loss should be sought. For example, major hemorrhage in electrical burns and ECG should be obtained. Further assessment and initial management of burn: first aid: cool the area with running water for up to 20 minutes but avoid hypothermia. Chemical burns should be copiously irrigated. Plastic cling film wraps can be used after cooling to limit evaporation from the burnt area. Pain relief should be provided immediately. Intranasal opiates are very useful. Estimation of burn surface area as shown in the figure. A burn diagram should be used as a rough measure. An area the size of the child's palm represents 1% of body surface area. Body surface area involvement determines need for admission and fluid management. Burn depth assessment should be attempted but is often difficult and unreliable immediately after the event. Further management: this should be directed at relieving pain. Assess with pain score. Intravenous analgesia such as morphine and ketamine is often required on an ongoing basis. Maintaining circulation: intra-IV fluids are required if ever If over 10% of the body surface area is affected, urine output is the best measure to assess the adequacy of fluid replacement. Provision of wound care. Superficial burns with erythema only are treated with simple exposure. Small superficial partial thickness burns can be cleaned and dressed. They should heal spontaneously but require review. Partial thickness burns covering over 5% of body surface area, deeper partial thickness burns are and full thickness burns should be reviewed by specialist burn service. Deeper burns will often require debridement and skin grafting to ensure a good cosmetic outcome. All burns to the face, ears, eyes, hands, feet, genitalia, perineum, or a major joint, even if less than 5% to 10%, should also be referred to specialist burn service. Signs of an infection should be monitored and treated if found, as there is a risk of significant invasive infection. For all burns, the possibility of inflicted injury must be considered. Psychological support should be provided if required, as psychological sequelae of severe burns often marked and long lasting. Now in the picture, this is a schematic diagram showing London Broder chart for accurate assessment of body surface, and which shows chest and trunk is 13 and forearm is 1.5, palm is 1.5, and shoulder and arm is upper arm is 2, and from the front and back perineal area is 1, from the buttocks is 2.5, and area indicated as B and C is thighs, and C is leg area, and palm is 1, and surface area indicated by ABC according to surface area at 1 year is 8.5, 5 years is 6.5, 10 years is 5.5, and 15 years is 4.5. The area of the thighs is indicated as B. At 1 year is 3.25, at 5 years it's 4, it's at 10 years is 4.5, and it's at 15 years and 4.5. At number C, the leg area, 1 year is 2.5, 5 years 2.75, 10 years is 3, and 15 years is 3.25. The depth of the burn, 3 areas, areas of the skin: epidermis, dermis, and subcutaneous tissue, showing when epidermis is involved, and it is superficial burn. Epidermis and upper area of dermis is involved. Partial thickness is superficial, partial thickness is deep if epidermis and whole dermis is involved, and its full thickness if subcutaneous tissue is involved. 2. Superficial, it's limited to epidermis, and it is possible causes sunburn, minus scald and dry, and erythematous. Pain sensation is painful and healing is rapid in 1 week. Partial thickness, superficial, scald is present, moist, erythematous, blistered, and painful. Pain sensation is painful in 1 to 3 weeks. Partial thickness, deep, scald, brief contact with flame, moist with white slough, erythematous and mottled, and pain sensation is painless in partial thickness, deep. 3 to 4 weeks often requires grafting, and full thickness, significant flame contact, dry, charred wire, and it's painless, needs skin grafting to heal. In burn management, cool the burn, not the child. Burn children requires effective analgesia. Refer deep or extensive burns or burns to sites where scarring would be particularly troublesome or disfiguring to specialist burn services. Next is poisoning. Poisoning in children may be accidental, common in young children due to deliberately self-harm or experimentation with recreational substances by adolescents or young people. Iatrogenic as a result of drug errors occasionally made by health professionals, intentional by parents or carers, though this is rare. Accidental poisoning usually occurs when Young children are found by parents or carers either playing with tablets or household or garden substances or with some in their mouths. The peak age is 30 months and typically exposure occurs in the child's home. Serious harm is uncommon as many common household substances medications have low toxicity and children usually ingest only small amounts. The relative toxicity of some common medicines and household and garden substances shown in table. A small number of medicines are potentially fatal to young children, even in small doses. Most common causative agents vary from country to country due to differing availability of medications over the counter and variation in rural and urban lifestyles. These have shown there has been a marked reduction in the incidence of severe poisoning from accidental ingestion by young children. Reasons for this include the introduction of child-resistant containers for many medicines and household products and use of blister packs for medicines. Reduction in the number of tablets available per pack in analgesics bought over the counter, adolescent attempting self-harm also typically ingest medication commonly found in their environment. Paracetamol and ibuprofen, with their wide over the counter availability, are the most commonly ingested substances. However, they are likely to have ingested much larger quantities of tablets than young children and are therefore more likely to suffer significant toxicological effects. In the picture shown relatively toxicity following ingestion of some common medicine, household, and garden substances. Toxic medicines of low toxicity, oral contraceptives, most antibiotics, and topical hydrocortisone. Household products with low toxicity include liquid soap, lipstick, washing up liquid, fish food, water based glue, and a paint. In a gardens, animal feces, slugs, geraniums, and compost. And high toxicity medicines are opioids, beta blocker, tricyclic antidepressants, oral hypoglycemics, paracetamol, digoxin, iron, and salicylates. Household products which are highly toxic are strong bleach, concentrated oven cleaner, liquid nicotine, ethylene glycol, which is antifreeze, and petroleum distillates. In the garden, laburnum, death cap mushroom, yew, foxglove, organophosphorus, pesticides, and kerosene. Investigations and management approach. An outline of to the investigation management potentially poisoned patient is outlined. Detail of some of the more common ingested food will be specific management are detailed in table will discuss later. Usually the identity of the ingested substance is known. Occasionally poisoning is suspected, but the substance is unknown. Clinical science may then help to identify the class of causative agents. These can be useful to aid further investigation and treatment. All older children and young people who have attempted to deliberately harm themselves must be assessed for risk of repeated attempt, irrespective of the toxicity of ingested substances. Risk of recurrence is increased by a number of factors, including ongoing thoughts of self-harm or suicide, a lack of regret, evidence of planning, for example, leaving a note, and a lack of protective social factors. The social circumstances of young people who inadvertently poison themselves as a result of experimentation with illicit drugs or alcohol should also be explored, with onward referral to substances misuse services where appropriate. Young children who have been exposed to agents of low toxicity and are asymptomatic can typically be discharged with advice to return if symptoms develop. The circumstances surrounding the exposure need to be considered to determine if there are social issues such as inadequate supervision that need to be addressed. Chronic environmental poisoning. Young children are a high risk group for chronic environmental poisoning because their exposure potentially occurs when they are most physiologically susceptible. Their engagement in frequent hand to mouth activities during play and meals leads to ingestion of more contaminants in dust and dirt than adults. Their small body size makes them more susceptible to doses that would not harm an adult, and their developing brains are at greater risk of permanent damage due to neurotoxic effects of exposure. Lead poisoning is one of the most important chronic environmental toxins affecting children worldwide, although it is now uncommon in the UK and other developed countries. In some developing countries, contamination of water supplies and the home environment by mining processes and factories remain a significant problem. The symptoms of chronic lead exposure are non-specific but include behavioral changes, hyperactivity or decreased activity, developmental delay or loss of developmental milestones, chronic lead nephropathy. More common exposure may result in abdominal pain, vomiting, constipation, headache and ataxia, lethargy, seizure, and coma. The most important treatment is to prevent further exposure to lead. Chelation therapy can be effective in reversing acute symptoms such as encephalopathy. Treatment is complex, particularly as lead is deposited in bone and therefore has a long half-life. Although acute exposure to organophosphorus and carbamate pesticide results in well-known acute syndrome, there is growing evidence that chronic exposure to these in early life can have adverse effects in neurodevelopment and behavior. In addition, there is evidence associating some pesticide with an increased incidence of leukemia and brain tumors. Now we will discuss the picture management of a poisoned child or young person, outline of management, identify the agent, question parent, child or young person, clinical symptoms and sign may help where history is unclear, determine toxicity of agent, consider intrinsic toxicity, use poison information service, reported dose ingested, presence of symptoms, time since ingestion, is reduction of absorption possible, indicated activated charcoal. High surface area leads to absorption of many drugs, can be effective in reducing absorption of toxic agent if administered within 1 hour of ingestion. Ineffective for iron, hydrocarbon and pesticides. Gastric lavage and induced vomiting no longer recommended. Our investigations indicated journal blood test, full blood count, renal and liver function, dependent on mechanism, likelihood of toxicity, ECG for drugs with cardiovascular toxicity. Specific blood concentration only helpful for paracetamol, iron, salicylates, and alcohol. Urine toxicology screen not helpful in the acute situation but may help to confirm diagnosis. Clinical management mainly determined by toxicity of agents. Specific management including antidote as directed by Poisons Information Service. Assessment of circumstances of ingestion important to prevent future recurrence. Assessment by child and adolescent psychiatrist on or mental health service in case of deliberate self-harm. Now this table shows all the poisons listed and their treatments. First agent is paracetamol. Clinical symptoms are early abdominal pain and vomiting late 12 hours to 24 hours is liver failure, initial gastric irritation, toxic metabolite NAPQI produced by saturation of liver metabolism, risk assessed by measuring plasma paracetamol concentration, treat with IV acetylcysteine if concentration is high or liver function abnormal. Button batteries, abdominal pain, gut perforation and stricture formation, leakage, corrosion of gut wall due to electrical circuit production, X-ray of chest and abdomen to confirm ingestion and identify position. Endoscopic removal is recommended if in the esophagus the object fails to pass or symptoms are present, for example abdominal pain or melanoma. Carbon monoxide early is headache and nausea, and later is confusion, drowsiness leading to coma, bind to hemoglobin causing tissue hypoxia, high flow oxygen to hasten dissociation of carbon monoxide. The role of hyperbaric oxygen therapy is unclear. Salicylates early is vomiting and tinnitus, later respiratory alkalosis followed by metabolic acidosis. The mechanism of salicylates is direct stimulation of respiratory center and couples oxidative phosphorylation leading to metabolic acidosis and hypoglycemia. Plasma salicylate concentration 2 to 4 hours after ingestion helps to estimate Toxicity: alkalization of urine increases excretion of salicylates. Hemodialysis also effectively removes salicylates. Tricyclic antidepressants: early is tachycardia, drowsiness, dry mouth, later is arrhythmias and seizures. Anticholinergic effects: interference with cardiac conduction pathways. Treatment of arrhythmias with sodium carbonate. Supports ventilation. Ethylene glycol is antifreeze. Early is intoxication, later is tachycardia, metabolic acidosis, and leading to renal failure. Production of toxic metabolites that interfere with intracellular early energy production. Formipizole inhibits the production of toxic metabolites. Alcohol may also be used but has more adverse effects. Hemodialysis to remove toxic metabolites in severe cases. Alcohol, accidental or experimenting by older children. Hypoglycemia, respiratory failure, direct inhibitory effect on glycolysis in the liver and neurotransmission in the brain. Monitor blood glucose and correct if necessary. Support ventilation if required. Blood alcohol level may help to predict severity. Next agent is iron. Initial is vomiting and diarrhea, hematemesis, melena, acute gastric ulceration, latent period of improvement 6 to 12 hours later, drowsiness, shock, liver failure with hypoglycemia and convulsions. Long term gut strictures. Mechanism is local corrosive effect of gut mucosa. Disruption of oxidative phosphorylation in mitochondria leads to free radical production, lipid peroxidation, or metabolic acidosis. Management of serious toxicity: if more than 75 mg per kg, serum iron level 4 hours after ingestion is the best lab measure of severity. Intravenous desferoxamine chelates iron and should be administered in cases of moderate to severe toxicity. Hydrocarbons, for example, paraffin and kerosene, pneumonitis, and low viscosity and high volatility make aspiration easy, results in direct lung toxicity. Direct inhibitory effect on neurotransmission in the brain. No specific antidote, supportive treatment only. Organophosphorus, pesticides, cholinergic effects: salivation, lacrimation, urination, diarrhea and vomiting, muscle weakness, cramps and paralysis, bradycardia and hypotension, central nervous system effects, seizures, and inhibition of acetylcholinesterase resulting in accumulation of acetylcholine throughout the nervous system. Supportive care: atropine, often in large doses, as an anticholinergic effect, pralidoxime to reactivate acetylcholinesterase. Now, physical findings that may help identify different classes of drugs in overdose. Types of effect and heart rate and blood pressure. In anticholinergic, for example, tricyclic antidepressants and antihistamines, heart rate and blood pressure is increased, respiratory has no effect, temperature is increased, pupils are dilated, and sweating is reduced. In opioids, morphine and codeine, heart rate and blood pressure is reduced, respiratory rate is reduced, temperature is reduced, pupils are constricted. Sympathomimetics, cocaine, amphetamines, heart rate is increased, respiratory rate is increased, temperature is increased, pupils is dilated, and sweating is increased. And sedative, hypnotics, anticonvulsant, and benzodiazepines, heart rate is reduced, respiratory rate is reduced, temperature is reduced, pupils have no effect, and sweating is reduced. Now, in the end, the case history: a 14-year-old girl with vomiting, abdominal pain, Jemima. A 14-year-old is brought to the emergency department in the morning by her mother as she has been vomiting and complaining of severe abdominal pain. On examination, she has a journey tender abdomen. Blood tests reveal an extremely high alanine transaminase concentration, well above normal for her age. Her clotting is also deranged with a prothrombin time of 17 seconds. Initial diagnosis of hepatitis is considered, but on discussion with the consultant, a lack of jaundice is considered atypical. On further direct question, Jemima admits to having taken 22 paracetamol tablets, 500 mg, the previous afternoon following an altercation with another girl at school. Jemima is commenced on N-acetylcysteine and makes a full recovery. This case highlights the need to consider toxicological cause when the history, examination, final investigation results do not fit together. Now, the summary: accidental poisoning in children is common in toddlers and young children. Most substances do not cause serious illness. When an ingestion has occurred, identify the agent and assess its toxicity to plan management. Poisons potentially harmful in children include alcohol, acids and alkalis, bleach, digoxin, batteries, iron, paracetamol, petroleum distillates, salicylates, and tricyclic antidepressants. Assess the social circumstances behind why it happened. This is the end of chapter 7. Thank you.